Now we're going to talk about antibodies and the various roles that they play in terms of immunology, immunopathology, as well as potential targets for pharmacology. So remember that where they're coming from, an antibody is produced by a plasma cell. And how that process happens essentially is you got a B cell, which we've talked about. So you have your mature B cell, or perhaps even naive/mature. You see those words used interchangeably. And in that B cell, you have an IgM B cell receptor, which is going to be basically IgM, and you have IgD. And remember, IgD is not going to be something that's ever secreted, right? But it's part of this B cell receptor. This B cell encounters something that matches to its particular pocket there, its B cell receptor. And remember, it's something like, I don't know, 10 to the 10, 10 to the 11. We went through that whole differentiation process, or at least the highlights of it, in terms of recognizing this particular antigen. And then what happens is, remember that the B cell can present to the T cell. Is it an antigen presenting cell? So it processes this particular antigen and it takes it to the T cell, right? So the T cell has, and it's again a similar reaction, this guy has an has an MHC class II molecule, right? And this has the CD4 molecule, and you have this reaction, right? The T cell receptor. So this receptor, in terms of its specificity, along with that pocket, along with this specificity, are matched. So they say, hey, I recognize you, you recognize me, and this is how this reaction happens. And then in addition to this, just like with regard to a dendritic cell, the CD4 positive T cell has a CD28 marker, and then this has that co-stimulatory molecule, which is going to be your CD80, 86, or we call it B7-1, B7-2, all the same molecule. So it's a start the car, put it into drive here, all right? So that's the reaction between these two. And then what essentially happens is there's an activation, and this B cell starts to proliferate into more B cells. It can become memory cells, memory B cells, that are going to be out there in the system. So this first reaction takes place in this secondary lymphoid tissue, all right? And then that's going to proliferate, and it's going to take some time, maybe a week, something, 3 to 5 days or so. Later on, though, this memory B cells can be out there, and they can activate, they can get on the job much faster, okay? So then that secondary response is going to be much, much faster. So you have a memory B cells. Well, lo and behold, you also start to have plasma cells, and those plasma cells, remember, they look kind of like a thumbprint because they have a whole lot of ribosome in them. If you look at them on an electron micrograph, they tend to show those on tests sometimes. And those plasma cells start to secrete antibodies. And the first antibody that they secrete is an IgM antibody, which we talked about. Now, as this starts to happen and you start to get more IgM secreted out there and you start to proliferate this process, you can have what they call isotype switching. So isotype switching, let's talk about that for a second, the actual structure of what's being secreted, all right? So maybe we can put it over here. So an antibody essentially has these components. It has a light chain, and it has a heavy chain, right? And so when we're talking about the light chain, those can be your kappa or your lambda, kappa or lambda light chains, right? That's not very, I drew the lambda upside down, but not both. It can be one or the other. So you'll see kappa lambda or a kappa or lambda light chains. So those are the light chains. And then you've got the heavy chains, all right? So then you have the heavy chains, and those are going to, again, those are not going to mix and match. In this region here, all right, that is going to be called Fab. That's your Fab region. And I say Fab-Nab. That's the part that is going to recognize the particular antigen, whatever that is, all right? And this part, even if you switch from IgG M to IgG to IgE. This never changes because remember it was specific for a specific antigen. But you can change this other the other portion of it. You can change this part of it, with regard to isotype switching, which we'll get to in just a second. In this part, you have an Fc receptor, or Fc portion, not receptor. Remember, the macrophages have an Fc receptor, the NK cells have an Fc receptor, and then of course you've got the with regard to mast cells and eosinophils. But you also have a complement section here, also binding to complement. All right, so those are kind of the major aspects of this. Now, when we talk about isotype switching, again, is not going to be this portion that's specific for the antigen. How does the isotype switching happen? Well, we introduced it before, but the T cell has a CD40 ligand, and the B cell has CD40. And there's a reaction, there's a bonding here between these two, and that's how you get. So if you imagine the more interaction you have between the P cell or B cell and the T cell, the more chances you're going to have the CD40 ligand, CD40 molecule binding, the more chances you're going to have to isotype switch into these other types of immunoglobulins. All right, and so that's how essentially the isotype switching happens with regard to the T cell and B cell interaction. Let's see if there's anything else that we want to talk about with regard to this. So I think it's good to discuss quickly. Okay, so you had a plasma cell. It secretes the antibodies. What are the antibodies going to do? All right? Well, think of it sort of logically. Well, one thing is an antibody can bind to an antigen. So here's an antigen, and here's an antibody, right? And remember, this is the Fab region here, okay? And this would be the FC region, complement. Okay, and this is another part of the Fab region. So I think of it like one of those boots that they put on your car when you parked it in the wrong place, right? And you can't move the car. It's the same kind of thing. If this particular, let's say, virus or something, bad guy were to get an antibody on him, he can't now get into a cell. He can't do his normal dirty work as he might have liked to have, because he's got this, he's got this sort of, ball and chain, if you will, around his neck. So that's one component of antibodies. And oh, by the way, when we started talking about TNF a minute ago, we had an for example, anti-TNF, all right, or certain antibodies with regard to ICAM, adhesion, where we're trying to turn off the immune system. Again, these antibodies can shut down the function of these particular mechanisms within the immune system. So you'll see that as well. Okay? Now, so that's one component of it. Another component of it is an antibody can be bioactive. Like take, for example, which we'll get more into, is Graves' disease, right? So you have an antibody that's acting like essentially TSH, thyroid stimulating hormone. So it's acting on your thyroid, and it's causing, essentially, it's pretending like it's thyroid stimulating hormone, so you start increasing your production of thyroid hormones, T4 and ultimately T3. So that's another way that you can activate it. Of course, a lot of diseases are associated with antibodies that shut down the process. So, for example, myasthenia gravis. So I'm just sort of beating a dead horse, but it's important because, at least for me, it wasn't always intuitive. So if you have a reaction here with the nerve, and you have the neuromuscular junction, and you have these acetylcholine, right, acetylcholine receptors and acetylcholine bubbles down here. Well, myasthenia gravis, if you have a antibody that essentially takes out the receptor, makes it inactive, then you're not going to be able to properly send the acetylcholine and start the cellular cascade. So that's another example of an antibody. Remember that antibodies also activate complement, the classical pathway, all right? So you have your IgM, only one molecule can activate complement, or you have several, molecules of IgG can activate complement. What does complement do? Well, you get the C3b which we've talked about with regard to opsonization. Now you got a macrophage that can opsonize that, or it can take it all the way to the membrane attack complex, in which case that particular cell, if he's a pathogen, can be lysed. Even if he's not a pathogen, he can be lysed in terms of immunopathology on your own system. So that's another example of what an antibody can do. What else? Let's think. Okay, NK cells, right? Antibody dependent cytotoxicity. So the NK cells they also have the ability to have an antibody receptor. Antibody's bound to this. NK cell sees it, and it can obviously start that cascade that's going to kill that particular cell. So it can either activate something in the case of a disease, Graves for example, inactivate it in the case of, let's say, a drug target, or inactivate it in the case of myasthenia gravis. It can cause the activation of complement, or it can also cause NK cells. And we'll talk even more about antibodies when we get to hypersensitivity reactions, which I think you'll find very interesting. So let's do some questions on antibodies. So the first one is, which of the following of the molecular interaction is required between a B cell and a T cell in order to get immunoglobulin class switching? All right, so the first reaction I'm discussing there is just an immuno reaction or a cellular reaction with T cells, but it's not specific to immunoclass switching. And B is, those are just the ICAMs and inflammation we talked about. So the answer is C, CD40 on the B cell and CD40 ligand, or another name for it, again, the famous, like to name two things, is CD154 on the T cells. So the answer is C. Number two is, if this interaction asked about in question number 1 did not occur, what would be the predominant immunoglobulin found in the serum? In other words, if you couldn't class switch, what is the primary immunoglobulin? What's the first immunoglobulin you see? And the answer is B, IgM. And that happens to be an immunodeficiency. Some people can't class switch. If they can't class switch, then they have a deficiency in terms of being able to fight, as we've talked about before, a number of bacterial infections, a number of different pathologies that we'll go more into. Number 3 is, where is secretory IgA located to? All right, so we talked about isotype switching, how it happens, and we talked about M and G and E and A, okay? Whoops, sorry, IgA. Let me just give a word about IgA. We talked about the fact that it's like an immunopaint, the secretory piece of it, and it's going to paint your mucosal surfaces. It's going to paint the lumen, for example, of your gut, so that's where it's going to be. So the answer would be A, the lumen, all right? It's not in the lamina propria, it's not on the basolateral side of the cell, it's the immunopaint. But another word about IgA is, number 1, it's the most common immunodeficiency out there, like something like 1 out of 300 of us. So if we don't have immunopaint, then we're going to be subject to, like, for example, sinopulmonary infections. We're going to be perhaps as well subjected to certain gastro infections. And even though we normally think of IgE with regard to parasites, an exception in this pool is with regard to Giardia. Giardia, you need IgA. So if you get a patient that's frequently getting Giardia, you might consider that they have an IgA deficiency. And again, it's varied in terms of how much or little IgA deficiency that you might have in terms of how it manifests, the degree to which you're suffering from various infections. The other thing about IgA deficiency commonly tests is the question of, okay, well, if you have a deficiency, let's just give you IgA. No, bad idea, because it'll cause an anaphylactic reaction. You don't ever give IgA. In fact, you have to be really careful about transfusing patients with IgA. My understanding, due to the fact that a lot of us have just IgA in our blood, in which case you can cause, again, an anaphylactic or a hemolytic type of a reaction. So IgA is something that is a favorite test question. Number 4 is dimeric IgA, once again, is found in the what and has a what chain. So it's found the dimeric form, not secretory form. Dimeric form is in the lamina propria and has a J chain. Number 5, which immunoglobulin has the longest half-life? Approximately 3 weeks. So lasts the longest, and that's going to be IgG, which is the answer in number B. And then 6 is, we spoke about it with regard to complement, which IgG subtype cannot activate complement, and that's IgG subtype 4. Again, it's kind of detailed. You might get it on an immunotest. I haven't seen that in the review books, but for completeness sake, we've got it in there. Number 7 is isohemagglutins. What are they? Okay, so the answer there is they're antibodies present in serum against non-self blood types. So let's just have a quick word about blood types. So we know that you've got your type, A, B, let's say O, and you also have AB. All right. So what this is saying is an isohemagglutinin. Let's just pick one so that we don't get too confused. If I'm blood type A, okay, so that means that my antigens on my RBCs are type A. All right. So I've got an A antigen. That's my calling card. All right. Now, what do I have antibodies for? I have an antibody for type B. Okay, so that's the isohemagglutinin that I have is for type B, for example. And realize that A, B are not the only antigens on red blood cells. There's a lot of others, and if you're going to transfuse a patient or you're going to do a transplant, they match all this stuff up. Okay, so, but this is the big picture in terms of A, B blood type. So that's the isohemagglutinin in terms of that. Now, what if I'm blood type O, right? We know that O is the universal donor, right? So O is a universal donor, meaning that they have zero, they have nada calling cards. So they have nothing, they have no essentially antigens, right? So I don't see any antigens. There's nothing here to see for my red blood cells. So O can be the universal donor and can be transfused all day to me, and thank you very much. All right. However, if I or you, let's say you are blood type O, all right? So you don't have any antigens, but you got antibodies for everybody, right? So you have an anti-A and you have an anti-B. So you can't take my blood. You have to have an O. You have to have one of your own, so to speak. O's have to have their own, and so they're not going to be able to take somebody else's blood from an A or B type or AB type. So that's where that's just a quick and dirty on isohemagglutinins. Well, actually, there's another question. Number 8. Your patient is blood type O. Which of the following would cause her to suffer hemolysis of the infused blood? Okay, and we just talked about that. It would be donor A, donor B, or donor of group AB. Why? Because she's got antibodies to all those, but she has no antigens on her little red blood cells, so she can give you her blood all day long, which is very nice for her. Number 9 is IgA. Another important point that I missed is true or false. IgA is found in colostrum. Remember, colostrum is that big push, that big first push out of the breast for the little guy. All right, and it's very critical to their, because it's chocked full of all kinds of immunological goodies. And yes, in fact, it is in IgA is found in that. Now, number 10, which immunoglobulin crosses the placenta? And that's going to be B is IgG, as we know. When we get into immunopathology, what's very interesting is that you don't typically see a lot of immunopathology with regard to antibodies straight away when a child is born, because they've got mom's antibodies for about 6 months, okay? They have her IgG for about 6 months. But after that, they're on their own, and that's when you start to really see the immunopathology start to rear its head if, for example, they have a B-cell type of a pathology. Number 11, true or false? A fetus with Rh positive antigens. So remember, we talked about blood group AB, but you also have this Rh positive, rhesus antigen positive or negative. antigen there. What is it? D, I believe D antigen, if I remember correctly. Not important, but essentially a fetus with Rh positive antigen is in danger of RBC hemolysis if her mother is Rh negative, and that is in fact true. So remember what happens is, the first time, let's say that mom is Rh negative, okay? Whoops. Mom's Rh negative, and we're talking about her first pregnancy, and there's no crossing there in terms of the placenta and the little guy with regard to this Rh antigen, okay? Because the first little guy is Rh positive. But then, birth is a messy process. Or let's say she miscarries, or let's say she has an abortion, or for whatever reason, there's a crossing of the blood types, okay? And then her little guys, her immune system sees this Rh positive and starts creating antibodies. Mom starts creating antibodies against the Rh positive, the little guy. These antibodies are IgG. She gets pregnant with number 2. IgG crosses the placenta and blows up the little guy's red blood cells. Okay, so this is causes a hemolysis. So that's the process of that. And then number 12 is, we didn't talk much about immunodiagnostics. We'll try to throw it in here and there. But one of the questions that they do like to ask is with regard to a direct or an indirect Coombs test. So number 12 is, if you want to test the mother's serum for Rh positive antibody, remember, she's Rh negative, but the little guy's Rh positive. Which test would you perform, a direct Coombs or an indirect Coombs? So this is the way I think of the Coombs test, and we can go into it later. But essentially, if you're just seeing in the serum, okay, in a test tube, that's a test tube. If you're just looking for an antibody in the serum, just hanging around in the serum, okay, that is indirect. So I think antibody, sort of 2 words, indirect, okay? Indirect Coombs. If, on the other hand, you wanted to see if, for example, the little guy, his RBC had, an antibody onto it, if you wanted to see that the cell had an antibody already onto it, or antigen or what have you, then you could do a direct. Okay, so if it's just the antibody in the serum, then you're indirect Coombs. If it's on the cell itself, then it's direct Coombs. And let's see if there's anything else I can think of. I think it's better to go into hypersensitivity in another lecture or another discussion. Thank you.